Hello all and welcome everyone. Good evening in Southeast Asia region and good afternoon in UK region. Welcome all to this webinar series exploring gross examination and frozen section. This is the third webinar in this four-part series, and today's webinar is titled Gross Examination Frozen Section on Gynecological Pathology and Oncology Specimens. My name is Professor Kedar Devdar, and I'm the regional advisor for the Southeast Asia region for the Royal College of Pathologists. With Giles Hendrati, who's an international education officer of the Royal College, we have created this program with guidance from Professor Martha Cohen, who is the Vice President of Learning of the Royal College. Let's see our agenda today. Briefly, I will give you first the overview of the entire series. Then we'll have a lecture on gross examination and frozen section of the gynecological pathology oncology specimens by Dr. Divya Midha. The lecture will be from about 70 to 75 minutes. Then we'll have Q&A sessions. If you have any questions throughout the presentation, you are welcome to write those, put them in a Q&A box below, and we'll aim to answer them later in the series. To give you an overview, we had planned this as a four-part series, and we have had two lectures so far. On 5th of February, we had lecture on head neck oncology specimens, how to handle those and frozen sections. The second lecture on the 12th was actually on the breast cancer oncology specimens. And today is a third lecture on the gross examination and frozen section on the gynecological pathology oncology specimen. On the last or the fourth lecture in the series will be colorectal carcinoma specimens, and we'll have an eminent speaker for that as well. So these were the four lectures that we had, and last line tells us gives us a link to the Royal College of Pathology's website where we find these conferences. So if you go to the Royal College of Pathology's website, GEFS, this is what is circled here. This gives you the webinar series information, but mind you, each candidate will have to register for all these lectures individually, and we can't register those all in one go. So please mind you, register for those separately. Today, I'm glad to announce that we have Dr. Divya Midha, who is a senior consultant and oncopathologist from Department of Oncology, Oncopathology, Tata Medical Center, Kolkata. Dr. Divya Midha has taken time to give us this overview. Dr. Divya Midha is a very experienced pathologist in gynecological pathology. Her interest lies in not only gynepath, but also soft tissue pathology, lung pathology, cytology, as well as urological pathology. I think we'll hand over to Dr. Divya Midha for this lecture. After her lecture, we'll go on to the Q&A sessions. Dr. Divya, over to you now. Yeah.
Hello, everyone. Thank you, Dr. Kedar. Thank you, Giles, for having me as a speaker at the Gross Examination and Frozen Section webinar series organized by the Royal College of Pathologists, UK. I'm Dr. Divya Midha, joining you today from Kolkata, India. And I will be taking you through a rather exhaustive journey covering some salient features of gross examination of select gynepathology and oncology specimens. So when we talk about grossing in histopathology, we must know that this is the first step in diagnostic process before microscopic examination. It is the initial visual examination of the tissue sample with the naked eye, and it's very important because it identifies the most relevant areas for further microscopic analysis. And this is extremely important because this will lead you to an accurate diagnosis, an accurate staging, and accurate treatment planning. So why is grossing important? So when we are grossing, we are looking at tumor size, we are seeing the extent of invasion into the surrounding structures, we are seeing the involvement of the lymph nodes, and whenever we are accurately grossing, we are therefore accurately staging. And when we are accurately staging, our clinical friends, clinical colleagues can give the patient the best course of treatment. When we tell them the accurate status of margins, they can plan the adjuvant treatment as well. Also, gross examination is very important for intraoperative decision making, the so-called popular frozen section reporting, and very important decisions are taken by the surgeon on the table. And in the era of precision medicine, during grossing, we can take appropriate tissue samples for further molecular testing. So the key points about grossing, which I think all pathologists should know, when you're grossing a specimen, you should know about the anatomy of the specimen. You should be able to orient the specimen on the basis of the anatomy or by basis of certain pointers given by the surgeon. He may put some sutures, he may put some clips, or you may take help in the grossing room, call up your surgical colleagues and your friends and ask them to come and orient the specimen for you if you're having difficulty. You must be aware of the clinical details, the prior biopsy and the cytology results, the prior radiology findings. And since we're talking about oncology specimens, you must be aware of the various staging systems which pertains to that specimen, the FIGO or the TNM staging. And of course, you should have access to some important data sets depending on which region you are coming from, the RCPAT data set, the RCPA data sets, the CAP protocol, the ICCR data sets, which will help you in the histological reporting of the tumors. So in today's lecture, I'm going to give you an overview of three important specimens. We'll study the gross examination and sampling of hysterectomy specimens for only endometrial cancers. That's because we can't cover a lot. So we'll stick to endometrial cancers. In section 2, we will talk about the gross examination and sampling of specimens of cervical cancer. And in the third section, we'll talk about the gross examination and sampling of specimens of tubal, ovarian, and peritoneal cancers. And in each section, I'm going to take you through the anatomy, the orientation of the specimen, the staging, the margins, the important grossing procedures, which tissue sections to take. And in the end, we'll just briefly look at the important frozen section scenarios in each of these relevant specimens. So coming to section 1, we're going to talk about the hysterectomy specimens which deal with endometrial carcinomas. So we know that in 1983 there was a dualistic classification for endometrial carcinoma, type 1, type 2. Type 1 was endometrioid and type 2 was the non-endometrioid, that is the serous or the clear cell. There was a lot of overlapping between these two and there was a lot of subjectivity involved. 30 years later came the molecular classification of endometrial carcinoma, and this is the hot topic these days. And this is the TCGA study published in Nature, which is the integrated genomic characterization of endometrial carcinoma. Now, TCGA divided endometrial carcinoma into 4 categories. And this is the ultra-mutated phenotype caused by the DNA polymerase Pol E mutations, the hyper-mutated phenotype caused by DNA mismatch repair deficiency, and leading to the microsatellite instability, the copy number high, which was associated with TP53 mutations, and if it didn't fall under these 3, it was the copy number low or the no specific molecular profile. So there are surrogate markers for this particular molecular subtypes. So for the P53 group, we have the P53 IHC. For the MMRD group, we have the MMR IHC. And for Pol E, unfortunately, there is no surrogate IHC marker. We have the Pol E mutation. If the 3 do not work out, then you're dealing with a no specific molecular profile or a copy number low. Now, the WHO, the recent one, it basically addresses these classification, and in the current WHO 2020 addresses the molecular classification of endometrial cancer and also gives us a few special types as well. So it is recommended that all histotypes of endometrial cancer be subject to Pol E status first. If Pol E is pathogenic, it's a Pol E mutated endometrial cancer. If Pol E is wild, the MMR status is determined. If it is deficient, it's an MMR deficient endometrial cancer. If it's proficient, then you do a P53 status with the P53 IHC. If it's P53 mutated, it's a P53 abnormal endometrial cancer. Otherwise, it's a P53 wild and therefore a no specific molecular profile endometrial cancer. So what is the role of the pathologist? In the endometrial biopsy, we have to determine the histological type and determine the tumor grade. On the basis of our report, the resection specimen, the type of surgery is planned. So for example, if we say it's a low-grade endometrioid cancer, we'll get a hysterectomy with a sentinel lymph node biopsy. If we call it a serous carcinoma on our endometrial biopsy, we'll get a more extensive surgery in the form of omentectomy, pelvic, para-aortic lymph nodes. So it's very important that we classify our tumor type and tumor grade accurately on the endometrial biopsy. What do we do on the resection specimen? We give the type, we confirm the grade, and we give all the staging parameters, and that's what we're going to talk about today. We have to molecularly subtype the cancer on the basis of the IHC surrogates, which we spoke about, P53 and the MMR IHC, and of course, if resources permit, we can do the Pol E mutation as well. On the basis of our report, the endometrial cancer is then risk stratified by our clinicians for management, and this gives us the ESCO, ESTRO, ESP guidelines for the management of patients with endometrial carcinoma, which divide the risk groups into low, intermediate, and high on the basis of the material we provide to the clinician in terms of the stage, the grade, the LVSI, etc. So it is very, very important that we very accurately gross our specimens so that we are able to give all this information to our clinicians and they are able to risk stratify the endometrial cancer and then start the treatment. The treatment for low risk may be no adjuvant and the treatment for high risk is chemoradiotherapy. And then of course there are the intermediate risks which come in the middle. So our grossing is of utmost importance so that we can accurately stage the endometrial cancer. Once we stage, the risk stratification is done and then the patient is given the adjuvant treatment on the basis of that. Now, coming to the staging of endometrial cancer, this is the older staging, the FIGO 2009 staging, which was an anatomical staging. And in this, the T1 cancers are the ones confined to the corpus uteri. And it's 1A when the myometrial invasion is less than 50%, 1B when it's more than 50%, T2 when it invades the stroma, T3A when it invades the serosa and or the adnexa, 3B when there's vaginal and or parametrial involvement, and 3C when it's involved the pelvic and the paraaortic lymph nodes. It is stage 4 when it goes to the bowel or the bladder mucosa, or it goes to the omentum, intra-abdominal metastasis, and to the inguinal lymph nodes. So you can see from this that the FIGO 2009 staging of endometrial cancer is an anatomical staging. Now, in FIGO 2023 has come up with a new staging of endometrial cancer, and this updated system incorporates all non-anatomical parameters in an attempt to make staging more personalized and relevant for patient prognostication and management and to align with the ESCO, ESTRO, ESP guidelines. It has received some criticism as well, and we are wondering if this cancer came in with too much information and came too soon. Now, coming to the FIGO 2023, the highlights are it incorporates tumor type and tumor grade. It pays attention to cancers which are aggressive and non-aggressive. It incorporates LVSI as a staging parameter. It incorporates the size of the lymph node metastasis as a staging parameter. It introduces a stage 1A3 for synchronous low-grade endometrioid and ovarian endometrioid carcinoma. And most importantly, it integrates the molecular classification of endometrial carcinoma into the staging system. And these are the data sets which are very popular and one can follow them for reporting endometrial cancer, the Royal College of Pathologists, the CAP and the ICCR guidelines. And the International Society of Gynepathologists also set out to develop the guidelines for the diagnosis, reporting, and ancillary testing of endometrial carcinoma. And this was termed the Endometrial Carcinoma Project, and papers that have come out from this, that is the grossing paper by Dr. Malpika et al., has been of tremendous help in establishing guidelines on how to gross uterine specimens which are harboring an endometrial carcinoma. And this is also a recent review article by Dr. Talia et al. And this is an excellent resource material when you want to gross gynecological specimens. Now, coming to the clinical data items for reporting endometrial carcinoma, patient demographics, of course, are important. The specimen type is important because you need to know what type of a surgery was this. Was it a simple hysterectomy, which is removal of the total uterus and the cervix only? Whether it is a radical hysterectomy, which includes the uterus, cervix, parametria, upper vagina, and the uterosacral ligaments. It's important that you know all these parts of the hysterectomy. It's also important to know which route was done to do the hysterectomy, whether it was abdominal, whether it was vaginal, or whether it was laparoscopic. This is important because laparoscopic hysterectomy using balloon manipulators can result in artifactual vascular pseudo-invasion. For a pathologist who is looking at the microscopy slides, it's very important to distinguish pseudo-invasion from true invasion. As I said earlier, previous biopsy results are very important because this is going to guide the further HPE correlation and the IHC results. A family history of endometrial and colon cancer is important because of the importance of Lymph syndrome. So these are the types of hysterectomy, the specimens that can come to you. It can be a total hysterectomy with bilateral salpingo-oophorectomy. It can be a supracervical hysterectomy or a radical hysterectomy with bilateral salpingo-oophorectomy. And as I said, previous biopsy results will guide the surgeon on the type of the resection, and then we can further stage the tumor. Now, Lymph syndrome is extremely important because it's a hereditary syndrome caused by germline mutations in DNA MMR genes, and this has a 40 to 60% risk, lifetime risk for endometrial and colon cancer. And endometrial cancer is often the first or sentinel cancer in a pedigree, and it precedes the other cancers by approximately a decade. So it's really important that we know if there is a family history of endometrial or colon cancer in that particular patient. And the diagnosis of Lymph syndrome in a family will therefore allow surveillance and preventative measures that significantly reduce the mortality from the subsequent cancers. So coming to the anatomy of the uterus and the cervix, so you can see the uterus and the cervix, and if I can use my pointer, sorry, may I use my pointer? Right. So you can see the uterus and the cervix over here, and this is the anterior part where the peritoneal reflection is a little higher, and this is the posterior surface where the peritoneal reflection is on a posterior aspect. And again, to orient the uterus, this is another great picture which shows you the anterior surface where this is the peritoneal reflection, and you can see over here the round ligament anteriorly, followed by the fallopian tube with this arrow, and then the ovary. This is the posterior part when you orient, because the peritoneal reflection is right below over here. Now, it is important when you're grossing your specimen, once you've oriented it, you can weigh the specimen. You may measure the uterus in 3 dimensions. The maximum would be superior to inferior, the maximum intercornual, and the maximum anterior to posterior. This will give you the 3 dimensions of the uterus. The cervix is measured in 2 dimensions, anterior posterior, that is 12 to 6 o'clock, and transverse 3 to 9 o'clock. Also, one should know what is the accompanying specimens. So the ovary, mention the laterality and measure it in 3 dimensions. The fallopian tube, mention the laterality and mention the dimensions of it, that is the length into the diameter. Coming to the other accompanying specimens, the omentum may be accompanying the specimen, measure it in 3 dimensions. It's very important that you record the presence and dimensions of the largest visible deposit. And this is a very important feature, and we will be discussing about this a little more in detail. Now, the lymph nodes, we have to identify them. We should know whether they are sentinel or non-sentinel. The pelvic, para-aortic, you should know the stations, the numbers recorded from each anatomical site in separate labeled pots. Also, you should be aware if peritoneal biopsies have been submitted from each of the anatomical sites. You should measure and record any gross abnormalities. So coming to a very, very important part, which is inking of the specimen. The inking of the peritoneal on the non-peritoneal surfaces is recommended in hysterectomy specimens, and inking should be done prior to opening the uterus. And it's mandatory in radical hysterectomy specimens because there you have to, the parametrium is there and the vaginal cuff is there, and these can serve as very, very important margins. So for a simple hysterectomy, the mucosal margin will be the ectocervical mucosal margin, and the cervical and the paracervical would be the soft tissue radial margin. But for a radical hysterectomy, your bilateral parametrial soft tissues will be your true surgical margins, and the vaginal cuff will be your mucosal margin. So this is a picture over here which shows you the margins. So this is over here is the soft tissue on the anterior and on the posterior aspects, and this you have to ink it. And these pink arrows that you see over here is the distal mucosal margin, which corresponds to the outer edge of the ectocervical mucosa. This is the pink arrowhead that you see here. And the radical hysterectomy also has these bilateral parametrial soft tissues, and which should be inked, and these are very important margins. So the key is you ink, then you open the uterus, and then you record the distance of these margins from the tumor. Now, this is just to show you a very important feature that what is the benefit of this inking? Now look at over here, you've inked the specimens, and now this is a tumor which is, because of inking, you can easily identify that this has touched the serosa, and this makes it a stage 3. So this is very important that you ink. It'll be very easy when you're looking at your microscopy. In this figure C, you can see that the tumor has involved the endocervical stroma. This is the endocervical glands, as you can see, and this is the endocervical, the tumor which is invading the endocervical stroma. Now over here you can see there is inking of this section, and the tumor has invaded the cervical stroma, and you can over here measure the full thickness of the cervical wall and also measure the depth of invasion. And this is the margin over here, your ectocervical margin in the star, and you can easily measure the distance of the tumor from these very relevant vital margins. So inking is going to really help you in assessing your margins. All right. The next important step would be to inspect the serosa of the uterus. Now, it's normally smooth and shiny, as you can see in this yellow arrow. Normally, it looks like that, but there may be certain abnormalities which you may be you should be careful about. There could be involvement of tumor where it starts looking rough or gray white, or it shows a sort of a break in the serosa. There can be hemorrhage, there can be adhesions, there can be some tumor nodules. Over here, what you can see in these black arrows over here, these are some brownish, blackish, spots of endometriosis. So this is just to show you the shiny serosa here and the brown spots of endometriosis. The next important thing after you've inked the specimen is opening the uterus. And how should this be done? The scissor should be inserted and you open along the lateral walls of the uterus. Do not amputate the cervix. So when you are looking at an endometrial carcinoma, you already know it's endometrial carcinoma, you've received the prior biopsy, you insert the scissor and you open along the lateral walls without amputating the cervix. And this is what you get after you have amputated the cervix. Without amputating the cervix, you open the lateral walls. You can see two halves of the uterus. If you have bivalved, now it is anterior half and posterior half. It allows better visualization. You can measure your tumor easily. And in this method, it prevents autolysis, which may affect the accurate grading and the histotyping. And it avoids pre-analytical issues for further ancillary testing. Now, after you have opened up the uterus, you inspect the endometrial and the cervical mucosal surfaces. You look for variations in thickness. You look for lesions with irregular, indented, or frankly infiltrative borders. You look for discoloration, ulceration, necrosis, hemorrhage. You look for any satellite lesions. You look at if there are any polyps adjacent to it. You note the size of the tumor or the lesion, and you record its largest measurement. You see what is the location of this tumor and what is the appearance of the tumor. So this is a picture which shows you a tumor over here, if you can see, and it's gray white and it's infiltrating. The tumor here is protruding into the endometrial cavity, right? And here you can see a polyp at the fundus. So it's very important that you inspect your endometrial mucosal surfaces very diligently. This is just to show you two different areas. This is your endometrial tumor, and this very well circumscribed whorled area is a leiomyoma or a fibroid. So you should be able to distinguish between what is tumor and what is a fibroid, which is a very common feature in a uterus. All right. Now we measure the tumor size after you have opened the uterus, and a tumor that involves the anterior and posterior walls in a continuum like this, for example, these two walls, if it involves it in a continuum, this is how it should be measured in a continuum. This is a rather large tumor and it has been opened in the manner that I told you. And this is how we measure the the tumor which is occupying both the anterior and posterior walls in this continuum fashion. All right. So why is it important to accurately know the tumor size? Number one, it is usually very large tumors are associated with LVSI, with lymph node metastasis and the risk of recurrence. Also, if you know the tumor size, you know how many sections of the tumor you need to take. So it's very important to document the tumor size. For uterine sarcomas, which we're not going to go into today in detail, the maximum tumor size is a staging criteria. For other mesenchymal neoplasms like smooth muscle tumors, PCOMA, inflammatory myofibroblastic tumor size comes under the risk stratification. So it's important that you measure the tumor size, and the largest dimension of the tumor has to be reported. Very important that you should know the tumor site as well, because a lower uterine segment tumor is associated with mismatch repair deficiency, and it's predictive of lymph node metastasis and recurrence. And it's very important when you're sampling a lower uterine segment tumor that you should be able to distinguish it from an endocervical carcinoma, because the staging, prognosis, and management of an endocervical adenocarcinoma is very different from an endometrial carcinoma. And this is the common table which you see in many books. So you can distinguish endometrioid, endometrial carcinoma from an endocervical carcinoma on the basis of the gross, on the basis of microscopy, and also on the basis of immunohistochemistry. Now, coming to the sectioning of the uterus and the cervix, you have opened it, you have know the tumor size, location, etc. Now, the sectioning is the last step prior to tissue fixation, and it has to be done very diligently. You should cut the uterine and the cervical wall at regular intervals between 5 and 10 mm, horizontal transverse sectioning from the lower uterine segment to the fundus, and vertical sectioning of the cervical wall to the cervical canal. So, this is the horizontal sectioning for the uterus between the fundus and the lower uterine segment, but as far as the cervix is there, you're going to do a vertical sectioning. The hysterectomy specimens should never be placed unopened in fixative. You should open, section, and then place it in a fixative, which is 10% neutral buffered formalin. Only after it has been sectioned. And you can place paper towels between the sectioned tissue to ensure that the fixative will reach the tissue. Now, for myometrial invasion, you see the maximum depth of invasion in millimeter, the thickness of the adjacent normal myometrium, and the minimum distance to the serosal surface. All this can be measured in millimeters. And for sections of the for histological examination, it's very important that you take 1 section per centimeter of the largest tumor dimension. And that is why it's very important that you know the tumor dimension, because this will guide your sectioning. Or you take at least 4 blocks. If the tumor is 2 centimeters or less, it should be submitted entirely. This is very important because this will ensure that you have adequately sampled the tumor and there is no chance of missing a higher grade component within that tumor. Take 1 full thickness section of the uterine wall, including the uterine serosa, representing the deepest myoinvasion, because this has a huge staging implication. Sample the tumor-non-tumor interface. 1 to 2 full thickness sections of the non-neoplastic endometrium myometrium should also be taken, because this will help you in assessing the deepest point of myometrial invasion, and will also, the adjacent endometrium will give you an idea about the precursor lesions such as atypical hyperplasia, atrophy, or even a polyp. Now, this is an example of a section that you take, the similar picture that I showed you. This is your endometrial tumor. This was invading only up till this much, and this is a leiomyoma. So this is a great section to keep. And you should take a section which is this one, which is which has got the maximum depth of invasion and which also has the serosa, and a full thickness section should be taken. And you can also take a photograph of it and then, put your block keys on it. This will help you when you're reporting. In certain special situations, for example, if there was a diagnosis of atypical hyperplasia in the prior biopsy, you may need to submit the entire endomyometrium or even the endometrium and the adjacent inner myometrium. In case you called it cancer before on the biopsy and now there is no grossly visible tumor, you should submit corneal blocks in case of biopsy-proven carcinoma. And in case of Lynch syndrome, if there is a family history of Lynch syndrome, submit the entire endometrium if no gross lesions, including the endomyometrial interface and the lower uterine segment with the upper endocervix. Submit all grossly visible lesions, and even the adnexa has to be sampled entirely. Right. Now, coming to cervical involvement, you should see whether the cervix is invaded or not. Note the maximum depth of cervical wall invasion if it is there, and the total cervical wall thickness in the region of maximal invasion. You should note the distance of the tumor from the ectocervical or the vaginal cuff margin, whichever type of hysterectomy. If it's a simple hysterectomy, you have an ectocervical margin. It's a radical hysterectomy, you have a vaginal cuff margin. And you should note the distance of the tumor from the radial margin. For the LUS and the cervix, you should take 2 longitudinal sections, 1 anterior, 1 posterior, and also for the cervix, 2 full thickness longitudinal sections, 1 anterior, 1 posterior. Please do take it with the margin, the ectocervical or the vaginal cuff margin, especially if the cervix is involved by tumor. This is because cervical stromal invasion is PT2 and the depth of cervical stromal invasion is used for adjuvant RT planning. An alternative approach is if the uterus is invading the cervix, you can take a continuum 1 to 2 longitudinal composite sections in serial blocks, which includes distal cervix, endocervix, LUS, and fundus in a continuum, and then you put them into those composite blocks. This will allow visualization of the tumor spread into the lower uterine segment and cervical wall. So this is another alternate approach. And these are the longitudinal sections of the cervix. This is what it looks like. All right, and this I've already shown you a microscopic example of endometrial tumor invading the cervix, and because it is inked, you can know the depth of the invasion into the cervical stroma and also the distance from the margin. And another picture from one of our cases, look at the ink at the margin over here, and this tumor is invading the cervical stroma, and you should be able to measure the depth and also the distance from the margin, which is very close in this particular case. So for the parametria, the parametrial margins should be painted with ink. You submit the parametrium before opening the uterus, which minimizes the chances of carryover. Section perpendicularly into sequential slices. If there is minimal or no parametria present, submit shaved sections of the parametria margin. This is an example of the tumor which is invading the parametrium. Now, what about the ovaries and the fallopian tubes? You section them perpendicular to the long axis at 2 to 3 millimeter apart. Submit at least 2 sections of each ovary. But in case of endometrial serous, clear cell carcinoma, carcinosarcoma, and all these tumors associated with Lynch and BRCA, you may have to submit the entire ovary. If the fallopian tube is uninvolved, you submit as per the CFIM protocol, which we'll talk about later, or sample the fimbria entirely as per CFIM and representative sections of the rest of the fallopian tubes. We'll discuss the CFIM in detail in a bit. So these are some of the sections which can be taken. The omentum is extremely important because it has a staging implication. Complete slicing at 5 mm interval, macroscopically examine and palpate to determine if any nodules are present, and then slice it at 5 mm interval. Submit 1 to 2 representative sections if it is grossly positive. RCPAT suggests you put 1 section of the grossly involved omentum, or 1 section per 2 to 3 centimeters, or at least 4 blocks if grossly negative. So this is a very important guideline which you should follow. All peritoneal biopsies should be submitted entirely and serially sectioned if more than 4 millimeter. Now, coming to the non-sentinel lymph nodes, all the lymph nodes should be identified, and for non-sentinel lymph nodes less than 2 millimeter, they should be submitted whole. For 3 or more in size, you slice it at 2 millimeter perpendicular to the long axis and submit them entirely. This will allow identification of the metastasis, which is classified, as we all know, into ITCs, micromets, macromets. The presence of ITC doesn't change stage, but the presence of micromets now changes the stage. So micromets versus macromets, the staging changes, as we discussed earlier. So there are various methods of, looking at your sentinel lymph nodes. We have the MSKCC ultrastaging protocol and the MD Anderson ultrastaging protocol, which are very popular. And one can follow these protocols and take, any one of them. Basically, what we do is we take if there is no mets on the initial section, you take further deepers and then you stain one with HNE, and then if it's still negative, you follow it up with a cytokeratin stain to pick up especially ITCs or micromets. So this is an example of metastasis in a lymph node of endometrial cancer. In our case, as you can see, this looks like a macromet in this particular case. And this is a case of sentinel lymph node ultrastaging where the ITCs were highlighted by cytokeratin. So the important pathological parameters for reporting endometrial cancer: the tumor size, tumor histotype, and tumor grade, the depth of myometrial invasion, because you're going to change from PT1A to PT1B. Cervical stromal invasion will be a PT2. Uterine serosal and adnexal involvement will be PT3A. Parametrial and vaginal involvement PT3B. Lymph node involvement with size of metastasis will determine your end stage. Biomarkers like HER2, MMR, and P53 can be done especially for Lynch syndrome, HER2 in cases of serous carcinomas, and these have huge treatment implications. And finally, a PTNM or a FIGO stage will be given, which will guide our clinicians into adjuvant treatment. Now, coming to the frozen section scenarios in endometrial cancers, a frozen section to determine endometrial cancers, they're not that popular, and the reasons I'm going to tell you in a bit. Sometimes we do get a request to determine tumor grade for a frozen section, or the depth of myometrial invasion for a frozen section. This is not a very common scenario. The reason is usually the tumor grade is assigned very accurately in the biopsies itself. The depth of myometrial invasion with MRI pelvis that is being done is accurately giving you the depth of myometrial invasion, or even cervical stromal invasion. So that is why the frozen sections to determine tumor grade and depth of myometrial invasion is not very popular. Sometimes tumor size is being asked intraoperatively because it is supposed to guide the performance of lymph node dissections. But now there are two alternatives which are there with us, which obviates the need for frozen section for endometrial cancer. Number one, there's a performance of lymph node dissection practically for every patient, especially the sentinel lymph node biopsies, without regard to the preoperative tumor type or grade. So this really obviates the need for frozen section for endometrial carcinoma. So with that, we finish the first section. Now we're going to jump headlong again to the gross examination and sampling of specimens for cervical cancer. All right. And again, you are very well aware of these data sets, and it is important that you look at the updated data sets. And I also draw your attention to the article on the grossing for endocervical adenocarcinoma. Now, it's freely available, and this will, though it is written for endocervical adenocarcinomas, it also applies for squamous cell carcinoma of the cervix. And you can use this free resource easily. Now, the salient changes which have occurred in all these data sets and the updated data sets is that a lot of importance is being given to small excision trachelectomy specimens. And of course, hysterectomy specimens are also alluded to. The term microinvasive carcinoma has been discouraged, and it is better to use the FIGO stage as a specific descriptor for a small invasive carcinoma. The classification of cervical carcinomas has been updated to WHO 2020. The clinical relevance and significance of HPV-associated and HPV-independent cancers has been alluded to. There's a pattern-based assessment for cervical adenocarcinomas, the Silva's method, that's also been addressed. The SLN protocols have been addressed, and P16 interpretation is also very important. Now, coming to the new FIGO 2018 staging, which differs from the prior 2009 staging. The 2009 staging did not address the lymph nodes, okay? But the 2018 staging has a lot of changes, and the important ones are there is subdivision of stage 1A on the basis of depth of stromal invasion only. So this was the 2009, which had the horizontal spread. Also here you have the depth is very important, and the 1A is split only on the basis of depth. And subdivision of stage 1B has been done into three on the basis of size criteria. Okay, so it was earlier 1B1, 1B2. Now there is 1B1, 1B2, and 1B3 on the basis of the size criteria. Most importantly, there's an inclusion of lymph node mets identified either by imaging or pathology in stage 3, which was missing in the prior 2009 FIGO definition. So the clinical management decisions are currently based on FIGO 2018 staging systems. This is just a thing which I wanted to bring about. So again, when we are dealing with any cancer, you have to know the full patient details. You should know the cervical screening history, the clinical appearance of the cervix on colposcopy, the results of the previous biopsies and radiological investigations, the details of prior surgical or non-surgical treatments, the details of the surgical procedure performed, because if you know the procedure, you know which parts to expect in your specimen. You should know the details of your surgical specimens, especially when they have been sent from multiple sites. All the specimen pots should be labeled, and you have to match them to the specimen and on your request form. So these are some prerequisites which you must deal with. Now, the types of specimens that we will be covering quite quickly would be Leep, LETs, the cone, trachelectomy, hysterectomy, pelvic exenteration, and we'll spend some time on lymphadenectomy. Now, what is a Leep or a cone? Now, these are procedures which are performed to remove precancerous lesions from the cervix. So the Leep or the LETs, it uses an electrical loop-shaped cutting device it cauterizes the tissue as it cuts through it, and this cautery can be used to identify tissue margins. Now, the cold knife, on the other hand, uses a gives you a cone by using a cold knife. It does not produce a cautery effect on the tissue edges. So this is a very, very important difference between leaflets and the cold knife conization. And this is just to show you a pictorial diagram of your cold knife biopsy versus your loop electrosurgical excision. So basically, when you get a Leep or a LETS, you may get various types of specimens in under a Leep or a LETS. You may get an intact cylinder, which is great. You may sometimes get 2 or more separate pieces, which makes things a little difficult. Sometimes a Leep may be a little fragmented. Sometimes you're going to get a Leep with a separate proximal endocervical canal, which is known as the top hat. So you should be aware of all these different scenarios when you're dealing with a Leep or a LETS. Now, this is an excellent diagram. I couldn't help but getting it from the paper on this extensive article which deals with the grossing of the cervix. So A, B, C, and D are the cold knife cone specimens of the cervix. And look at the different shapes, long and cylindrical, broad cylinder. Some of them are cube-like over here. So these are the different shapes of your cold knife specimens. And below are all your Leep specimens. This is an intact Leep. This is a Leep with a top hat, and this G and H are the ones where a Leep has become in this a little fragmented or disrupted during the surgical procedure, or sometimes the clinician or the surgeon may need to perform the Leep as 2 separate excisions like over here rather than as a single cylinder. And these 2 types are very challenging to produce well-oriented sections and gives the person who's grossing a little bit of cold feet. But let me just guide you through a few instructions which will probably help. So when you're dealing with a fragmented Leep, please remember that the ectocervical edge is shiny, smooth, and white. There's an ectocervical edge. And then there is an endocervical edge, which is pink, finely granular, and will have some adherent mucus to it. This deep connective tissue margin outside is your, the outer margin, and this is rough and cauterized. Now, because a cautery has been used, it will lead to a thermal artifact on microscopy, and this should distinguish a true margin from an edge created because of slicing or trimming the fragments. So actually the cautery helps you to identify the margin well, and that is a very big plus, and therefore inking of the specimen may not be mandatory in case of a fragmented Leep. Now the number of fragments are noted, and in case of a fragmented Leep, record the range of dimensions, record the dimensions. In case you see a macroscopic lesion, record that also. Now, the tissue sectioning of a fragmented Leep, you slice the tissue into 2 to 3 mm thick slices parallel to the endocervical canal so that you get mucosa along one edge. You get endocervical and ectocervical mucosal margins at the either end of this edge, and you get a deep connective tissue margin at the opposite side of the mucosal one. So all the tissue should be submitted for microscopic examination, and you try to keep only 1 to 2 sections in each cassette, just like this diagram. The reason is if you do keep more than 2 sections, it will cause a little bit of overcrowding, and this may lead to a proper misalignment, and an incomplete representation of the mucosa may happen. And in principle, you can take 1 initial H&E section should be enough, but in case you have a disrupted mucosa, or then you may need some deep H&E should be enough. Now, this is what I was talking about. When you see the section, you get mucosa along one edge over here. You can see the mucosa, and this is probably the lesion that of interest. You see the endocervical at one end here of the mucosa and ectocervical at one end. So endocervical mucosal margin is here, ectocervical mucosal margin is here, your mucosa is this, and this is your deep connective tissue margin opposite to the mucosal one. So this is what I was talking about when I was telling you about the sectioning. Now, coming to the intact Leep, usually the surgeon will be very kind and he will suture it at the 12 o'clock position, which will make it very helpful for us. You preserve this orientation for the subsequent block designation. You ink the ectocervical radial margin in one color, and you ink the endocervical. It's nice if you ink it in another color. Record the length parallel to the endocervical canal and the diameter and the wall thickness. And for the tumor measurement, you document the anatomical location of the tumor first with the O-clock position or anterior or posterior lip. Document the distance of the tumor from the endocervical, ectocervical and deep margin, and you document the tumor measurement. Tumor length parallel to the endocervical canal, tumor width perpendicular to the endocervical canal, and tumor thickness and the depth of tumor invasion. Now, for an intact leap, so this was a fragmented leap. For an intact leap, if the specimen has been sent to you fixed, so you have to serially slice it, just like as I showed you for the fragmented leap, and you can slice it like this, and the two lateral edges can be further sliced and placed on edge to produce perpendicular margin. So either it is sliced parallel like this, it's called the parallel slice strategy, or it can be done radially like this, where you're going to get wedge-shaped sections and which need to be trimmed at a later time. All right. Now, if the leap is sent to you fresh and it's intact, then this is what you do. After you have inked it, you are going to use scissors to open it at the 12 o'clock position, and then you're going to lay it flat. Then you're going to pin it, and then you're going to slice it at 2 to 3 millimeters to produce sections like this. For details, you must refer to this article, which is a great resource and of huge help. All right. Now coming to a trachelectomy. What is a trachelectomy? It is a fertility sparing approach for patients with selected stage 1 cervical cancers, particularly stage 1A1 with LVSI or stage 1A2 or B1 centered in the distal cervix. So basically, like a hysterectomy, even a trachelectomy can be simple or radical. It is simple when it consists of the cervix, that is ectocervix, transformation zone and endocervical canal, with or without the upper vagina. And if the vagina is there, it will be a cuff of only 1 to 2 centimeters. It's a radical trachelectomy the minute it includes the parametrial tissues. So this is the two types of trachelectomy which you may come across. And this is a very good diagram to show you the cervical face of the trachelectomy. This is the right and the left parametria, and this is the other side where you can see the endometrial canal. It is usually received intact and fresh. It requires a FS evaluation of the endocervical margin here, and the specimen orientation, inking, measurement should be done prior to fixation. Anatomical orienting of this specimen in the coronal plane, it is marked by the suture, usually at the 12 o'clock position. You ink the margins, as I told you, your endocervical margin, the vaginal margin, the right and left parametrial margins, and you also ink the surfaces on the anterior and the posterior surface of the cervix. You measure the cervix length parallel to the endocervical canal, the diameter and the wall thickness, measure the parametrial tissue from superior to inferior and from uterine wall to the outer edge, from the uterine wall to the outer edge, superior to inferior. Measure the vaginal cuff, minimal and maximal length, and this is done best after you retract it. Otherwise, it's going to cave in and you may not be able to measure it properly. Now you open this specimen again along the endocervical canal. Try to open it in an area which is free of the gross tumor. Opening will reveal the cervical mucosa. Measure the tumor dimensions. The open cylinder is now ready to be fixed. Pin the vaginal cuff to prevent retraction. Or alternately, you can even section the cervix fresh. Now, this is how you look at, this is a tumor, and you document its location as per O-clock, document the distance from the margin, and you measure the length parallel to the endocervical canal, measure the width perpendicular to the endocervical canal. If it's an exophytic tumor, you can measure the thickness, and the depth of the tumor can only be seen grossly after you have sectioned through it. So in this picture, you can only see the length and the width. And this is how the tissue sections are taken. You serially slice them at 2 to 3 millimeter interval parallel to the endocervical canal. Each slice should have mucosa along one edge, as I showed you, and a radial paracervical connective tissue margin on the opposite edge. And on the mucosal side, you will see vaginal cuff margin on one end and endocervical margin on the other end. So endocervical on one end, vaginal margin on the other end. And opposite to the mucosa, you're going to have the paracervical connective tissue margin. Now, if there is no tumor or the tumor is less than or equal to 2, you are supposed to entirely submit this specimen. If the tumor is more than 2 and close to a margin, then representative section should be taken. with the deepest tumor invasion and its closest approach to that particular margin. If the tumor is more than 2 and far from the margin, then again, you use the same strategy and take representative sections with the deepest tumor invasion and the closest approach to that particular margin. Now, coming to the tissue sections, the vaginal cup and its margins are left unattached to the cervix and serially sampled along with it. If it is too wide, the margin can be shaved and submitted as a shaved section. The parametrial tissue has to be separated from the cervix, sliced and submitted entirely. But if the tumor invades the parametria or is close to the parametria, let it be attached to the cervix and submitted with a portion of the outer cervix attached to it. Now, coming to hysterectomies specimen, this is a more common specimen, especially that we see in India. We don't see that many trachelectomies. So there are 3 types of hysterectomy performed for cervical cancer. The radical hysterectomy, which includes the uterine corpus, upper vagina, a cuff of 1 to 2 centimeters, and the parametrial tissue. The parametrial tissue is a very important part of a radical hysterectomy. A modified radical hysterectomy is a modified procedure. It is less extensive than radical and removes lesser tissue. A simple hysterectomy is not a very common specimen for cervical cancer. It consists of entire cervix and the uterine corpus with or without the vagina and no parametrial tissue. It is used only for FIGO stage 1A without LVSI. Otherwise, a radical hysterectomy is the more popular surgical procedure. And the orientation is similar to how you would orient a uterus in the cervix, which we've discussed earlier, the anterior and the posterior surfaces on the basis of the peritoneal reflection, on the basis of the position of the round ligament, the ovary, and the fallopian tube. Inking is also very similar to what we discussed when we were talking about endometrial cancers. You ink the ectocervical and the vaginal cuff margins. This is the margin here, and the right and the left parametrial margins should be inked. The non-peritonealized anterior and the posterior surface of the cervix should be inked. The uterus should be weighed. You measure the cervix, the parametria, the vaginal cuff, as we discussed in the trachelectomy specimen. You measure any visible tumor as in a trachelectomy specimen. You measure the uterus and the ovary in 3 dimensions, and you measure the fallopian tube in 2 dimensions, length and diameter. How will you now open the specimen? This is very important. So method 1 is, this is a good method for opening the uterus, the cervix. You amputate the cervix from the corpus. So it's cut off from the corpus and the cervix is opened and pinned and then sectioned like a trachelectomy, like how we discussed earlier. Now, method 2, the former method is not very popular for a bulky tumor. So if your tumor is very bulky, this is not a great method. For a more bulky tumor, you may do a method 2. In method 2, what we do is the cervix is left attached with the corpus. The uterus is opened along the lateral walls, resulting in an anterior and posterior half using scissors, and then inserting the forceps into the uterine cavity in between the forceps arms to guide the cutting. So this is done when the tumor is bulky. Now, coming to the details of opening the specimen, the cervical amputation begins with the inking, as I said. So you ink the parametrial margins. If you can slice off the parametrium, if there is no suspicion that the tumor is extending into the parametrium, you can just slice it off in B and C. Then D and E is when you are amputating the cervix from the uterus. Then you open it with the scissors, cutting through the wall. Then you open it, then you pin it. And then you're left with the uterus. You insert a scissor and then you guide your forceps and then you open it into an anterior and a posterior half. Now, the uterine corpus is then sliced in parallel thin slices, just like how you would do for an endometrial carcinoma. You slice the uterus in parallel slices. You stretch out the vaginal cuff to its full length and pin it in position to prevent retraction. And you fix in formalin overnight before further tissue sampling. So this is a very important part of your grossing protocol. Then you document tumor involvement in relation to the endocervix, ectocervix, parametria, and uterine corpus. Document the anatomical location of the tumor in O clock or the posterior lip. Document the distance from the margins, vaginal, parametrium, and the non-peritonealized and the connective tissue on the anterior and the posterior surface. You document the tumor length, tumor width, tumor thickness, and depth of tumor invasion. Now, the tissue sections, again, just like a trachelectomy, A cervix with no lesions or tumor less than 2 centimeters should be serially sectioned at 2 to 3 millimeter and submitted entirely. If the tumor is more than 2 centimeters, you do representative sections to include margins, vaginal cuff, parametria, and LUS. And for this, you may need composite sections if the canal is too long to fit into a single block. The vaginal margin should be taken perpendicular closest to the tumor. If there is no gross lesion, the entire vaginal margin can be put shave or representative perpendicular sections may be taken. The parametria is submitted entirely. The anterior posterior walls of the corpus and the LUS 1 or 2 full thickness sections should be taken. The fallopian tube by the CFIM protocol, or you may put the fimbria completely and representative sections of the ampullary portion. Ovaries, you may take representative sections. This is a pelvic exenteration specimen, and these are done for recurrent cervical or vaginal cancers in which adjuvant radiotherapy fails to control the disease, and in those where advanced stage cancer are suitable to extensive surgical resection. So this is the resection of pelvic organs along with uterus and vagina. In anterior exenteration, you have the bladder, urethra with or without ureters. In posterior exenteration, you have the rectosigmoid. A total exenteration includes anterior and posterior organs. So this is an example of a total exenteration where you can see the uterus, there's a cervical tumor, this is the bladder, and this is the rectosigmoid. It's a complex specimen, so you need to orient it by identifying the organs and some tissue landmarks. The ureters and urethra may not be very visible and you may require help from the surgical team. It always helps to take a gross photograph. For example, in this case, I do credit my fellows for taking great photographs. And you identify and measure all the organs in the fresh state, uterus and the bladder in 3 dimensions, the rectum, vagina, and ureters. You measure their length and the range of diameter. You ink the right and left soft tissue margins. Describe the tumor appearance, size, location with respect to the organs, whether the organ is involved or not. And these are the important margins that you may need to take. The urethral and the uretral margins shave. The proximal distal rectosigmoid margins shave. The vaginal margins best taken radial. And the pararectal, parametrial, paracervical soft tissue margins should be taken radially. Now, coming to the lymph node specimens, pelvic lymphadenectomy is a part of primary surgical treatment of all stages of cervical cancer except stage 1A without LVSI. And SLN mapping and biopsy of pelvic lymph nodes for early stage cervical carcinoma is recommended. And you do para-aortic when it is stage 1B1 and for higher stage cancers. Now, the staging of lymph node involvement depends on the size of the nodal mets. So the 2019 FIGO staging takes macromets and micromets as positive lymph nodes, and it is a stage 3C. Isolated tumor cells up to 0.2 mm do not affect stage. And the current AJCC staging criteria also classifies macro and micromets as PN1 and isolated tumor cells as PN0. So when you're grossing lymph node specimens, the idea is you should be able to reliably detect nodal metastasis of at least 0.2 mm. So this has to be done diligently. The pathologist should be able to determine which is a non-sentinel or a sentinel lymph node. And you should use your specimen requisition form and container label to determine the sentinel versus your non-sentinel lymph nodes. Now, for all non-sentinel lymph nodes, record the size and the number, remove excess adipose tissue, note the presence of any macroscopic involvement of the lymph node. Grossly involved lymph nodes, you may put a representative sections. Lymph node less than 4, you can bisect them. More than 4, you slice at 2 millimeter intervals perpendicular to the long axis, and this is how you submit and embed the slices sequentially. This is for a non-sentinel lymph node. And as I said, you can trim the excessive adipose tissue, document the number, and submit the entire tissue for microscopic examination. And usually a single H&E stain section per tissue block is sufficient. Now, sentinel lymph nodes have a different approach. You examine the lymph node and the adherent fat. You look for the presence and the color of the dye. Up to 2 millimeter, you embed the hole. 2 to 4 millimeter, you bisect and submit both the halves like this. And more than 4, you slice at 2 millimeter intervals perpendicular to the long axis, and you avoid any trimming of surrounding fat so that you can see extranodal extension. When the lymph node is trisected, the 2 end pieces should be placed cut surface down. The middle slice is placed randomly unless gross examination identifies a suspicious lesion. When lymph node has 3 or more slices like this, the non-opposing faces should form the cutting surface. So you can look at the guidelines, the RCPAT guidelines gives you a protocol which is jointly recommended by the BAGP and the BGCS. Now, the deeper level sections should be taken. For any section that is negative on the initial H&E sections, 2 sections are taken at a certain distance apart. We follow the 50 micrometer apart protocol, and you stain 1 with H&E and 1 for pancytokeratin. Now, number of levels and the distance between levels should be decided by local practice conditions, and the role of keratin IHC remains to be fully studied. However, it is very useful in size measurement, which will distinguish your ITC versus micromets versus macromets. And as I told you, this also has a staging implication. Now, coming to frozen section of sentinel lymph nodes, that is it being done intraoperatively? Now, it may be done to triage patients to proceed with radical surgery or to abort surgery and pursue chemoradiotherapy. Now, this is not a very popular method for getting frozen sections for sentinel lymph nodes, but we should remove excess adipose tissue. You slice a sentinel lymph node to a long axis at 2 mm interval, evaluate all the slices by frozen section. Do not perform deeper levels except if you want to look at some suspicious finding, but the ultra staging protocol can then be applied when you're looking at your permanent sections from the remainder of the frozen tissue block. Now, coming to the frozen section scenarios when you're dealing with the cervix, frozen section should be limited in case of cervical specimens and only done when the surgical management will change. Certain scenarios when your surgeon will ask you for a frozen section, and that is for a cone biopsy or a trachelectomy. In a cone biopsy, he may ask you for extent of disease or assess the invasion or to know the depth of invasion or your endocervical margin. This is done when your previous biopsy shows equivocal invasion or there is an uncertain depth of invasion. It's not a very popular thing to do, and it makes the pathologist a little uncomfortable. This is because there are certain disadvantages to it. There are numerous blocks and slides for every case. It's a very time-consuming procedure. You need to correlate with your prior biopsy, and small lesions may be missed or disappear in permanent sections. So it's not a very frequent request that you get. So you can sometimes put 2 sections and then try to process and see them, but this is not a very great method. The pitfalls while seeing a cone biopsy for frozen, it's difficult to evaluate the degree of dysplasia because they're freezing artifacts. It's difficult to look at your endocervical margin because of diathermy artifacts. And there are islands of squamous metaplasia which can mimic a stromal invasion. So beware of frozen sections on cone biopsies. A trachelectomy is asked for a cone. You ask for frozen sections, particularly of the endocervical margin. You have to report the presence or absence of in situ or invasive carcinoma at the proximal margin, which is defined by ink on the tumor. If the margin is negative, you record the distance between the tumor and the margin. The reason is, if your proximal margin or your endocervical margin is positive, then a radical hysterectomy will be done following a trachelectomy. If your proximal margin is negative but less than 5 millimeter, an additional portion of the upper endocervix may be removed and sent to you. The pitfalls you should be aware: margin artifacts, folds, tissue gaps, irregularities make it difficult to assess the proximal endocervical margin, and benign mimics, that is tubo-endometrioid metaplasia and endometriosis, may be mistaken for endocervical carcinoma. There are various methods which have been published for the intraoperative examination of trachelectomy specimens. You may go through them at your time. Now, for pelvic exenteration, you sometimes take this frozen has been requested from the main specimen or sent separately by the surgeon. If the tumor is far away from that particular margin, it should be taken shaved. If it is close, a perpendicular section should be taken. Sometimes frozen section from pelvic wall, abdomen or retroperitoneal area is also taken before proceeding to an exenteration. If it's positive for malignancy, exenteration is aborted. But the potential pitfall is these are many times post-radiotherapy specimens. So be very, very careful of radiation artifacts while looking at a frozen section and also crushing artifacts. Now, this is the minimum requirements for the pathology reporting of cervical cancer, and I think we covered almost all of them, including certain aspects of frozen section evaluation. Now, lastly, coming to section 3, which is the gross examination and sampling of specimens of ovarian, tubal, and peritoneal cancers. So this is the anatomy.
Sorry, can I interrupt
Yes,
for
sure.
1 second? No,
Sure.
we are doing very well, but one of the attendees have said that if you could speak slightly slowly, please. Yeah. Yeah.
I should speak slow and then I'll take more time then.
Slightly slowly. That's
Sure.
fine. We've covered most cervix and endometrium, and we are
Sure.
looking forward for the ovary and frozen and
Sure.
grossing. Yeah.
Okay, I'll be slow. Thank you.
Please.
So coming to the anatomy of the, when it comes to the ovary and the tube, we can see that the ovary is a paired oval-shaped organ measuring approximately 2 to 4 centimeters in diameter. They lie on the posterior wall of the pelvis, lateral to the uterus, and they are supported by the suspensory ligament here, the ovarian ligament here, and the round ligament over here. Okay, and the fallopian tubes are a pair of slender ducts. You can see over here they are around 10 centimeters in length, and they have these finger-like projections adjacent to the ovary. Now, again, these popular data sets will help you in the histological reporting of carcinomas and borderline tumors of the ovary, fallopian tubes, and the peritoneum. I again urge you to look at the latest guidelines because you have to keep yourself updated. Now, just a important word that data sets should be completed for both borderline as well as malignant epithelial tumors of ovarian, tubal, and peritoneal origin. And it is important to know that tumors of fallopian tube, ovary, and peritoneum are all staged in a same manner. Okay, so these are the two important things that I wanted to let you know. Now, how to stage ovary, tube, and peritoneal cancer? The FIGO staging system or the AJCC. Now, fortunately for this particular specimen, both these use 3 factors to stage and classify, and they are practically the same. So let's look at them. So this picture gives you the TNM as well as the FIGO. So the TNM is here and the FIGO is below. This is very important. Now, stage 1 is tumor confined to the ovary or the fallopian tubes. It is split into 1A and B. 1A is when the tumor is limited to one ovary or fallopian tube, and there should be no tumor on the surface of the ovary and the fallopian tube, no malignant cells in the washings. Now, 1B B stands for bilateral, when it is the same thing, but when there are 2 ovaries or fallopian tubes. Now, 1C is limited to one or both the ovaries with any of the following. If it's 1C1, there is a surgical spill or the surgeon has nicked the ovary. 1C2 is capsule which has ruptured prior to the ovary, or there are tumor deposits on the ovary or the fallopian tube surface. And then it gets worse, 1C3, when there is malignant cells in the ascites or peritoneal washings. Now, stage 2 is tumor involving one or both ovaries, but it has gone to the pelvis. There is pelvic extension, but below the pelvic brim, or primary peritoneal carcinoma. Okay, and that is 2A and 2B. Now, 3 is when it has gone outside the pelvis or has metastatized to the retroperitoneal lymph nodes. This again is subclassified over here, and it is important that you know 3A, B, and C, and we will discuss it when it comes to the sampling of the omentum. We will discuss it in greater detail. Now, stage 4 is when there is distal mets excluding this peritoneal spread, and the distal mets can be pleural effusion with a positive cytology. It can be parenchymal metastasis and metastasis to extra-abdominal organs or lymph nodes outside of the endometrial cavity. Or the abdominal cavity, sorry. So the capsule state is important because it says it's stage 1. If the capsule is intact, it is 1A or 1B. B stands for bilateral. If it is ruptured, it is 1C, and the rupture means during surgery, 1C1, before surgery or tumor on surface, 1C2, and malignant ascites, 1C3. Spread within the pelvis, to keep it short, stage 2. Spread outside the pelvis, stage 3, and the omental deposit, the cutoff is 2 centimeters. We'll discuss it when we go to the omentum. And metastasis is stage 4. So again, this has a list of core and non-core data items. The core items include patient demographics, specimen type, history of prior chemotherapy, prior biopsy and cytology results, capsule status, tumor markers when available, and the genetic status. So let us look at them in a little bit of detail. Patient demographics, you have to note, as I said, specimen type is important, and the reason is when multiple specimens are received, you should know what the different specimens are. Sometimes you'll get a very distorted specimen and normal anatomy is unclear. Therefore, you should know what specimen type you have received. A history of prior chemotherapy is very important because that will guide you to how to sample the tissue, particularly the omentum, because you have to do a chemotherapy response scoring on the omentum. Therefore, you should know whether a history of prior chemotherapy is there. And a prior biopsy and a cytology result will be very useful, because if you have your prior ascitic fluid positive, it is 1C3 already at least, and if it is a pleural fluid positive, you know it is at least a 4A. So these are very important for staging purposes. Capsule status extremely important for staging, because surgical spill, as I said, is 1C1, rupture before surgery or tumor deposits on the capsule is 1C2. Now, tumor marker results will also guide you. CA125 levels raised in epithelial tumors, AFP in germ cell tumors like yolk sac tumors, inhibin in sex cord stromal tumors. So these are the important request form and the core data items which you must be aware of. Now, coming to the genetic status, this is a non-core item, but you should be aware, because we know that ovarian cancer is a part of sometimes the inherited cancer syndrome, and the close to 1/4 of women with ovarian cancer have one of these syndromes, either the hereditary breast ovarian cancer syndrome, that is the BRCA1, BRCA2 mutations, or the Lynch syndrome, which we discussed for endometrial cancer. It can be a part of that as well. So 10% of primary tubal ovarian cancers and peritoneal cancers have a genetic basis. 90% are BRCA1, BRCA2 and are associated with high-grade serous, whereas 10% are MMR deficient associated with Lynch syndrome. And these MMR tumors are the non-serous histotypes, that is the endometrioid and the clear cell carcinomas. So the importance of knowing genetic status is that you know that high-grade serous associated with BRCA has an unusual morphology, which is known as the set architectural pattern, which is known as the solid pseudo-endometrioid transitional-like. So this is solid-looking area, pseudo-endometrioid and transitional. This is a very classic picture that you see in high-grade serous associated with BRCA mutations. So it's important, if you know the genetic status, you will look for these features. Now, also high-grade serous is associated with, as you know, germline or somatic BRCA, and these ones show better chemotherapy response. And now with personalized medicine, we know that they can be treated with PARP inhibitors. Now, the importance of knowing genetic status is also that patients with suspected germline BRCA mutations and their relatives can be referred for genetic testing and counseling of the screening for BRCA-related neoplasias. And very important is a prophylactic risk reduction surgery in patients with known BRCA1 or BRCA2 mutations, where you're going to completely examine the tubal and the ovarian tissue and try to look for occult tubal carcinomas or STIC, so that the patient can therefore be saved from these aggressive tumors. Also, as I discussed, there's an importance of Lynch syndrome, because endometrioid and clear cell and other endometriosis associated carcinomas are frequently associated with Lynch syndrome. So the core items we discussed under the clinical thing. Now coming to the core items in macroscopy, capsule status is very important. So is tumor site, the dimensions of the omentum, omental involvement, and size of the maximum omental deposit. Tumor dimension is a non-core item. Now, the operative procedure, you need to know what kind of a procedure was done so that you can match it with the sample that you have received. It could be an oophorectomy. It could be a salpingo oophorectomy. You can get peritoneal biopsies or peritoneal resections. You can get omental tissue or an infracolic or a complete omentectomy. In case of mucinous ovarian tumors, you can get appendectomy. You can get total hysterectomy with bilateral salpingo oophorectomy, with all these accompanying additional specimens. You should know the anatomical components present: the ovary, the laterality, the fallopian tube with its laterality, omentum, peritoneal biopsies, lymph nodes, appendix, uterus, cervix. So these are all the anatomical components. Now, the specimen may be weighed. There's little evidence how much this is important, but the specimen size should be recorded. And the reason is that if you have recorded the specimen size, that is the ovary size in 3 dimensions, you will know how to sample it, because there are sampling guidelines depending on the size. Tumor less than 10 centimeters, you submit 1 section per centimeter. So if you don't know your size, your sampling will not be efficient. So the fallopian tube is measured in 2 dimensions, length into maximum diameter. If it is abnormal, then you may mention it in 3 dimensions. And ovary is always measured in 3 dimensions, and this will give you a rough idea about sampling your ovarian tumor. And so these are the measurements that I was talking about. And you should measure the omentum in 3 dimensions. This is a very important point. And the reason is, if you measure the omentum in 3 dimensions, you will know your adequacy of omental sampling, how many sections to take of the omentum submitted to you. So that's also very important, and it's a core feature. Now, coming to your capsule status, the capsule status, as I discussed, is very important. Stage 1, if it's intact, 1A or B, and if it is ruptured, it is 1C. And during surgery, if it is nixed, it is 1C1. Before surgery, if it is ruptured or tumor on the surface, it's 1C2. And if there is malignant ascites or malignant cells in the washings, it's 1C3. So the capsule is extremely important. Usually, the surface does not require inking. But if you have an ink, it can be helpful at the possible site of involvement or at a capsular defect. So over here, you can see that the tumor has invaded the capsule, and this is highlighted by the ink. So it's always useful. So you examine the capsule for rupture, and it's got staging implication, as I discussed with you, and you must look at the intraoperative findings. Did it rupture during the surgery? Did it rupture prior to the surgery? This is very important. Look for adhesions, because adhesions means there is foci of capsular rupture. Look for entangled fimbrial end. The entangled fimbrial end needs to be sampled for precursor lesions. So this is a picture from our department when the tumor was nicked during the surgery. So this is a FIGO stage 1C1 at least to begin with. This is a picture which shows you tumor deposits on the surface, 1C2. This is the fallopian tubal serosa, which is showing tubal deposits. You should see whether it's intact, ruptured, fragmented. Does it have tumor deposits on the surface? Now, tumor site is also an important factor which you need to look into, and it has now guidelines are given as to where the tumor arose from, particularly when it comes to high-grade serous carcinomas, because we know that all high-grade serous carcinomas, or majority of them, arise from the fimbria of the fallopian tube. And so the fallopian tube site is determined if the high-grade serous carcinoma, there's a stick present, if there's an invasive mucosal carcinoma present within the fallopian tube, or if the tube is entangled with the ovary, forming a tubo-ovarian mass, regardless of stick, ovarian, or peritoneal disease. So all these things tell us that the site is the fallopian tube. So this is an example showing you your tubal epithelium, which is normal. There's something called the P53 signature, where the tube looks normal on morphology, but has increased P53 staining or overexpression. This is stick, where it looks abnormal and shows P53 mutations. So if the fallopian tube has stick, the site is the fallopian tube, the primary site is the fallopian tube. So this is a normal tubal epithelium. This is the tubal epithelium, which is showing high-grade nuclear features, which is P53 mutated with a high Ki67. And this is an example from one of our cases showing mucosal high-grade serous carcinoma, which makes the fallopian tube the primary site. So how are you going to identify stick or mucosal carcinomas or early high-grade carcinomas in your tube? The CFIM technique is an excellent method of identifying these early precursor lesions, in which the fimbrial end of the fallopian tube is amputated, sliced thinly at say 1 to 2 or 2 to 3 millimeter intervals longitudinally in the sagittal plane, and the remainder of the fallopian tube is sectioned transversely at 1 to 2 or 2 to 3 millimeters, and the entire fallopian tube is then submitted for histological examination. So the detailed examination will result in a 4-fold increase in the detection of precursor lesions or early microscopic high-grade serous carcinoma. Now, when should you definitely do the CFIM technique? When you have extra serous high-grade serous carcinomas, but you have 2 grossly normal fallopian tubes and grossly normal fimbrial ends. You must entirely examine the fimbrial end and the entire tube. Another indication is when a patient has a hereditary predisposition to tubo-ovarian cancer and a risk-reducing BSO has been done. In that case also, you should sample the fallopian tube by this CFIM technique, which I just described. There are also instances when breast cancer patients undergo BSO or bilateral salpingo-oophorectomy as a hormonal ablation as a part of their treatment for breast cancer. In that situation also, the tubes should be examined by the CFIM technique, because these patients may be a part of the hereditary breast ovarian cancer syndrome. In Lynch syndrome also, prophylactic hysterectomy is usually done because they are prone to endometrial cancers. They're also prone to ovarian cancers. So even in these patients, the ovaries and the tubes should be examined completely, and the tube should be examined by the CFIM technique. So in all these methods, the ovary should be submitted entirely, fallopian tubes should be seen by the CFIM technique, and a peritoneal wash cytology is also sent and should be looked into. Now, when you don't have to stick to the CFIM technique, it is when one of both the fallopian tubes is entirely or partially embedded in the mass. When it forms a tubo-ovarian mass, automatically the high-grade serous carcinoma is regarded as a tubal origin. Then you don't need to do the CFIM technique and put in so many sections. When there are other tumor types at Nexel or others, or in a benign case, you need not do the entire CFIM technique. You can do a modification of that. You document the presence or absence of fimbrial ends of the fallopian tubes, you submit the fimbrial ends entirely, and you submit representative transverse sections of the non-fimbrial tube. So these are the indications of doing CFIM completely, and in certain cases you may not do CFIM entirely. You may do a modification where you submit the fimbrial end entirely, but you submit only representative transverse sections of the non-fimbrial or the ampullary portion of the tube. Now, when is a site primarily ovary? When you have an ovarian mass in the absence of stick or mucosal tubal carcinoma, provided you have seen the fallopian tube by the entire CFIM technique, or you have microscopic involvement of the ovary by high-grade serous, but you have no stick or no mucosal tubal carcinoma by the CFIM technique. When will you call a site tubo-ovarian? You will call it when you're dealing with a small biopsy specimen, including a prior cytology sample. Sometimes we get an omental biopsy as a starting specimen. In that case, you may call it tubo-ovarian because you're not sure, you have not examined the entire tube. So in that case, you may call it tubo-ovarian. In this situation, you must do IHC to exclude the possibility of a uterine serous primary. You can also call it tubo-ovarian when you have no residual disease post-chemotherapy. Let me give you an example. This is a 63-year-old female with an omental biopsy. She was said to have bilateral adnexal masses on radiology. This shows you a tumor which is quite high grade. It is in micropapillary arrangement. These tumor cells are strongly positive for PAX8, strongly positive for WT1. Therefore, we know that number one, it is of Mullerian origin, it's PAX8 positive, it is WT1 positive, so it must be of tubal or ovarian origin and not of uterine origin, because uterine serous carcinomas are generally negative for WT1 or even maybe focal positive. And this is P16 block positivity, which is a characteristic of high-grade serous carcinoma. So in this case, we can call it a tubo-ovarian carcinoma because we haven't examined the tube completely. Now, when will we call something a primary peritoneal cancer? This should be assigned only in a primary debulking surgery specimen prior to chemotherapy and not post-chemotherapy, because after chemotherapy, we don't know whether the tumor has regressed in the tubes. So we should not call anything primary peritoneal post-chemotherapy. It can only be assigned in a primary debulking surgery prior to chemotherapy. Peritoneal high-grade serous carcinoma should be present in the absence of macroscopic or microscopic involvement of the ovaries, which have been sampled completely, including surface involvement or tubal mucosa. So after you've examined the ovaries and tubes completely and you don't find any serous carcinoma prior to chemotherapy, this is a very rare situation when you get peritoneal high-grade serous carcinoma, which is a primary site. But be very careful. This has to be confirmed by appropriate IHC. You should be sure you're not dealing with a mesothelioma, so the appropriate IHCs have to be done, like calretinin. WT1 will be seen in both mesothelioma and in high-grade serous of peritoneal origin, so be careful with WT1. Calretinin and other markers should be used in making a distinction between mesothelioma and high-grade serous carcinoma, or metastatic carcinoma and high-grade serous carcinoma. So this is how we do the site assignment. Now, coming back to the sectioning of the ovary should be sectioned sagittally through its full thickness at 3 to 4 millimeter intervals. If you have a cystic structure and you don't want to have a spillage on you, please try to cut a cystic ovary over a sink. Take a photographic record of the specimen. We've already discussed the sectioning of the fallopian tube by the CFIM technique. It is good if you fix it for 1 to 2 hours prior to sectioning because this will prevent sloughing of the epithelium. Tissue fixation, place the specimen in 10% neutral buffered formalin only after it is sectioned. You can use paper towels. Describe the the cut surface of the ovary. Do you see any normal ovary? Is it cystic, unilocular, or multilocular? Describe the cyst contents, the amount of fluid, whether it's blood filled, blood stained, clear, watery, serous, mucoid, gelatinous. If you find hair, sebum, teeth, if you're dealing with the teratoma, is there a small foci of solid areas within the cyst? Look at the internal surface of the cyst. Measure the cyst wall thickness. Is it smooth? Is it plaque-like? Does it have papillary excrescences? If it does, describe those papillary excrescences. Is it slender? Is it broad? Is it plebby? Describe the range of size that you see. So all these are going to be very, very useful when you see the microscopic examination. So these are the various cut surfaces that I could catch a hold on. Look at this. This is predominantly cystic. There are some yellowish blebs over here. This is ovarian cyst cut open, and you can see the hair and bone coming out. This is an ovarian cyst with the papillary excrescences just bulging out of the lumen. And this is multicystic ovary, lots of multiloculated cyst filled with mucinous material. And this is another portion which is just predominantly cystic. And here this is multiloculated, filled with mucinous material. Now, the solid component of a tumor, say it's completely solid, note the color, note the texture, note the consistency, see whether there is necrosis, hemorrhage, or calcification. Look at the cut section of the fallopian tube if it is involved. This is the size of the fallopian tube measured in 3 dimensions, and then this is the cut surface of the fallopian tube. How many sections to take? You will take the sections only after you have measured the ovary. 1 section per centimeter of the maximum tumor diameter. So it's very important to know your tumor diameter to make sure you have sampled your ovarian mass well. For mucinous neoplasms more than 10 centimeter, take 2 sections per centimeter. This is because mucinous neoplasms have a wide range, from mucinous cyst adenoma to borderline tumor to intraepithelial carcinoma to mucinous carcinoma. There may also be certain solid areas also. So you have to be very careful when you're grossing mucinous neoplasms. It is 2 sections per centimeter for a mucinous neoplasm. For borderline tumors, we follow the rules by the Bethesda 2004 workshop. At least 1 block per centimeter of maximum dimension if it is less than 10 centimeter. And this 1 block should exclude your smooth wall cystic foci. Don't just keep taking the smooth wall cystic foci. Take the solid or the papillary looking areas and take 1 block per centimeter for a neoplasm which is less than 10 centimeter. Any neoplasm more than 10 centimeter for a borderline tumor, you should take at least 2 blocks per centimeter. And say for a micropapillary serous borderline tumor, maybe more than 2 blocks, because you are probably looking for a low-grade serous carcinoma in this. So a little bit you have to be guided by your intuition and also by the type of the histology that you're seeing under your microscope. You may want to go back and sample more. For cystic lesions, you section the solid areas, the papillary growths, the solid tumor at the capsular surface, relationship of the tumor to the attached structures. You should take a cyst wall for a precursor lesion and any uninvolved ovarian tissue. For solid and solid cystic lesions, relationship to the capsule, tumor deposit, breaches of the capsule, unusual looking areas, heterogeneous areas, uninvolved ovarian tissue, all this should be sampled. For example, in this, I would definitely like to take the solid area along with these different hemorrhagic areas and then the cyst wall, etc. Now, omental involvement is very important. You should know the size of the maximal omental deposit. Completely slice at 5 mm interval and you microscopically palpate it and you determine the omental involvement and you measure the size of the largest omental deposit because this has got a staging implication. And remember, the cutoff is 2 centimeters. Now, microscopic tumor in the omentum is stage 3A2. Macroscopic less than 2 centimeters is 3B. Macroscopic tumor more than 2 centimeters is 3C. So it is very important that you measure your omental deposit very well. Now, how many sections to put? You put 1 section if your omentum is grossly positive and you have measured it accurately. 1 section is enough. But you put, if it is grossly normal, there are various guidelines. RCPath and RCPA and ICCR say put 4 to 6 blocks of your grossly normal omentum. 5 to 10 blocks are the CAP guidelines for SBT, that is serous borderline tumor, serous carcinoma, and immature teratomas. So they say 5 to 10 blocks if they are grossly normal. So the guidelines differ a little bit. But for post-NACT or post-neoadjuvant chemotherapy for high-grade serous carcinoma, you should put around 4 to 6 blocks to assess your chemotherapy response score using these guidelines. Now, the appendix is another specimen which may come along with it. Inspect and describe it. Look at serosal nodules. Look at the luminal dilatation. Look at the mucinous material within it. Because the mucinous neoplasm could be actually a tumor arising from the appendix, like a low-grade appendiceal mucinous neoplasm, which is involving the ovary as a secondary, as a metastasis. So it's very important that you look at your appendix. For a mucinous ovarian mass, the appendix should be submitted entirely. But for other ovarian tumors, you may take representative sections, the tip, the margin, and 1 to 2 sections if there is a nodule or a metastasis. The lymph nodes should be submitted in separate pots and record the presence of macroscopic involvement, representative sections of the grossly involved lymph nodes, and for uninvolved lymph nodes, submit entirely after you have sliced it at 2 to 3 millimeter interval perpendicular to the long axis. Now, the peritoneal biopsies are usually submitted in separate pots to us. They are labeled as per the site of origin. You must note them. If macroscopically normal, submit entirely. If macroscopically abnormal, then you can take one section. Sometimes the bowel also comes. You have to take sections from the margin. You can take shave margins if they are away, or both of the proximal and the distal margins. If the tumor is close to the margin, you can submit a radial section. And you should take 2 sections of the bowel wall with tumor with the closest involvement to the bowel mucosa, because the bowel mucosa involvement upstages the tumor. Palpate the fat or any lymph nodes within the perirectal or the whatever bowel segment that has been submitted to you, but do not do an extensive lymph node dissection. That is not required. But any palpable lymph nodes or easily identifiable lymph nodes should be submitted entirely. Now, these are certain core items under microscopy and certain non-core items which should be recorded when you are reporting or signing out an ovarian tumor or a fallopian tube tumor. The tumor type, the grade, the site of involvement, result of peritoneal cytology, the lymph node status, the provisional FIGO stage. For serous borderline tumors, you must pay attention to micropapillary architecture and presence of implants. The non-core items include the pattern of invasion, expansile versus infiltrative for a mucinous tumor. The subtypes of carcinosarcomas is a non-core item. The CRS scoring, coexistent pathology, IHC and ancillary data, and intraepithelial carcinoma for mucinous borderline tumor is a non-core item. Now, coming to the frozen section of ovarian neoplasms, this is the last segment of my talk. This is the most common gynecological specimen for frozen section, and the workup includes imaging and serum markers usually, but they are of low sensitivity and specificity. So a lot of load comes on us pathologists sitting at the hot seat to give a frozen section diagnosis. And this is crucial for determining the extent of surgery for an ovarian neoplasm, because the surgeon will do a cystectomy for a benign tumor, an oophorectomy or a limited surgical procedure staging for a borderline tumor in younger patients to preserve fertility. And if you call it an ovarian carcinoma, they're going to do extensive staging procedure. So it's important that you know the clinical history. It's important that you know the radiological findings if they are available. You should see the gross of the tumor. You have to take appropriate sections, and of course, microscopy and morphological interpretation is very important during a frozen section. With this, I'll just show you snapshots of some cases very quickly. Case 1 is a 48-year-old female, left-sided ovarian mass, 8 centimeter in greatest dimension. Outer surface was rough and there were adhesions. The cut surface was cystic with solid areas. So the areas from the cysts showed features of endometriosis. You can see the endometrioid lining with some tubal metaplasia and sheets of these hemosiderin-laden macrophages. But we did not stop at just sampling the cyst. As I said, there were some solid areas, and this was sampled during a frozen section. 3 to 4 sections were taken of the different looking solid areas, and every section, this is a frozen section image, showed these crowded glands in a lobular pattern with these squamous morules. And there was another solid area which was about to be missed during frozen section, but we had the presence of mind to take it. And this showed back-to-back endometrioid glands with no stroma intervening, and they were very atypical. The case 1 was an endometrioid carcinoma, FIGO grade 1, arising in a background of borderline endometrioid tumor and endometriosis. So your frozen section diagnosis does alter the further surgery. Case 2 is a 42-year-old female who had bilateral ovarian masses. They were 9 and 7 centimeter in greatest dimension, and there were surface deposits. The cut surface shows gray, white, and solid areas. The idea was to sample the surface deposits and to sample the gray, white, and the solid areas. So this is what the frozen section, initial section looked like. It shows a multinodular pattern of growth. The tumor was involving the surface. There were some looser edematous areas as well. On high power, we could see lots of lymphovascular tumor emboli. On further high power, the tumor had mucin in its lumen because of its bilaterality, surface involvement, multiple LVI, and this sort of a morphology with, gland formation. There were some signaturing cells in the background. This was thought to be a metastasis from a GI primary. So bilaterality, the size less than 10 centimeters, surface involvement, LVSI, hilar involvement, nodular pattern of growth, single cell infiltration, signaturing cells, dissecting mucin, all goes in favor of a metastasis of a mucinous carcinoma to the ovary rather than a primary ovarian mucinous carcinoma. So this was signed out as a metastatic adenocarcinoma involving bilateral ovaries with surface involvement and LVSI. And intraoperatively, the patient was found to have a gastric mass. Case 3 is a 38-year-old female, bilateral ovarian masses, 8 and 6.5 centimeters each. In this case, both the masses showed surface papillary excrescences. The cut surface was cystic with papillary excrescence. So this is a frozen section from one of the surface deposits which was taken. You go higher. This has got the hierarchical branching. There is no stromal invasion here. And you can see certain micropapillary-like areas. On higher power, there were micropapillary areas. And this was a micropapillary serous borderline tumor with surface deposits. Case 4, 42-year-old female, right ovarian mass, 9 centimeters in greatest dimension. Outer surface was smooth, but the cut surface was solid cystic. So this was the outer surface, as you can see here. You can see the normal ovary here. And this is the tumor, which is rather blue on frozen section. On going closer, it had these monotonous or, very bland looking cells arranged in microacini. There was some nesting pattern. The frozen section diagnosis was given. It was not looking like any epithelial tumor that we knew of. It was called, a descriptive diagnosis was given. It looked a little neuroendocrine, but we gave a descriptive diagnosis of tumors with tubules and nests and low nuclear grade. It wasn't looking like a high-grade tumor. Outer surface capsule intact. And in this case, we had to defer it to a permanent section for IHC and further workup. And this is a permanent section, quite similar to the frozen section, where you can see this well-circumscribed mass here. And it is showing nests of tumor cells, some microacini pattern, and it did show to me at that point, it did show like a salt pepper appearance of the nuclei, and we were thinking, is it a neuroendocrine tumor? But this turned out to be Paxate positive. So are we still in the Mullerian line? Are we still dealing with a Mullerian tumor? But no, the morphology was not like a surface epithelial tumor. And then we did further markers. It was TTF1 positive, thyroglobulin positive. The final diagnosis was a follicular thyroid neoplasm. It did not have normal thyroid with colloid-like structures. It had a rather follicular appearance, and this was thought to arise from a struma ovari. There was no immature neuroepithelium or other germ cell tumor components, and the thyroid gland was within normal limits. The last case was a 19-year-old female, left adnexal mass, tumor markers normal, 14 centimeters in greatest dimension. The capsule was nicked intraoperatively, and this is very important to know from your requisition form. The cut surface was necrotic, but you have to be wise when you're looking at a necrotic cut surface. Do look for certain focal query viable areas, and this is what happened. We found a focal whitish viable area which we sampled. And this is what it looks on the frozen section. This is the necrotic area, and this is the somewhat viable area. But the viable area showed just some spindle cells and a sprinkling of lymphocytes. And this showed some ghost outlines of cells. And even at this power, they were looking rather monotonous with rounded nuclei, small nucleoli, some clear cytoplasm, little difficult to assess because it was not entirely viable with a sprinkling of lymphocytes. So we sign it out as malignant neoplasm with extensive necrosis, focal ghost outlines of cells and sprinkling of lymphocytes seen. This germinoma cannot be ruled out, therefore to permanent sections in IHC for definite categorization. We didn't get many viable areas on the permanent sections as well, but when we did it on these semi-viable areas, SAL4, OCT34 were positive, CD30 was negative. There was not much overlapping of the nuclei, and we called it suggestive of dysgerminoma. The peritoneal wash cytology had no malignant cells, and since the capsule had been nicked, this was a stage 1C1. So with this, I complete this onerous task of this presentation, where everything lies under the shoulders of the pathologist. So he's carrying the load of the uterus, the cervix, the fallopian tubes, the ovary, and giving so much effort into grossing and then reporting it. And then at the end of the day, the clinical colleagues are having a relaxed day, and that's because we've worked so hard right from the beginning of the grossing up till microscopy and further with ancillary testing. So with that, I end my presentation. I thank Dr. Kedar for this opportunity. Thank you, Giles, for putting up with me. And a very big thank you to all my colleagues, especially to my fellows who take excellent pictures and who are very efficient at the grossing table. So this is to all you trainees and to my fellows as well. Thank you very much.
Thank you, Divya. For a splendid job. Actually, you had a very onerous task to cover cervical tumors grossing, endometrial tumors grossing, as well as ovarian tumors and grossing, along with frozen section. I think that's really wonderful, and thank you. So let's. There are actually many questions. If we can have maybe next 15 minutes to go on to the questions. We'll take those and try to do justice to many people who have actually asked for many practical ground level questions. And maybe last 1 or 2 minutes I'll leave for myself for some housekeeping arrangements. So if we can go to the questions. One of the question was how do we stage an endometrial carcinoma with extensive with extension to painted serosal margin and rectal serosal deposits without involvement of rectal mucosa? So maybe I'll just go to the Q&A sessions. Right. Okay. Yeah. Maybe I'll read it. It's better this way. So how do we stage an endometrial carcinoma with extension to painted serosal margin and rectal serosal deposit without involvement of rectal mucosa?
Okay, so if it involves the serosa of the uterus, it is a stage 3. Right? Rectal serosa, it's still a pelvic organ, right? So if you can see from the anatomical staging here, if it involves the serosa, it is a 3A, right? Vaginal and parametrial involvement is a 3B. Now, only if it goes to the bowel mucosa will it become a stage 4. So otherwise, other structures in the pelvis will remain as a 3B. What is your take on this, Dr. Kedar?
No, I think that's fair. But 3A and 3B actually is very difficult. But mainly I think the operable cancers which come to grossing table are going to be actually a relatively low stage disease, and these are very uncommon situations that we will face. Next question is actually a bit interesting. Why do you need to slice the non-sentinel lymph node at 2 millimeter thick interval?
Because again, you have to, the classification and the nodal staging is also done on the basis of the size of the mets. Micromets versus macromets is going to change your nodal staging. That is why we need to cut it at 2 millimeter interval so that you pick up your 2 millimeter size. So that you've seen it at every 2 millimeter, you'll pick up the main aim of grossing these lymph nodes is to pick up micromets, because micro and macro are going to change your staging depending on whether it's pelvic or para-aortic. Okay, so your idea behind 2 millimeter would be to get that. That means you've seen every 2 millimeter of it, and you are getting that 2 millimeter size mets, and to pick up your micromets. The stage changes.
Right. Thank you. The next question actually is regarding grossing. Am I right in understanding you ink and open or slice extensively your fresh specimens? I put, the person is saying that I put a partial midline incision into the uterus for fixation, but don't do any further cuts until after fixed. I tend to complete the transection and continue to cut up in the sagittal plane later on. So it's basically pertaining to this the practice of inking and slicing before fixing or after fixing.
So it's always recommended that you ink, then you open. So inking is extremely important, particularly in radical hysterectomies. As I showed you from the gross pictures, I've shown you with the microscopy that inking will take you far, ahead in your microscopy. You'll pick up your serosal involvement. If it's invading the cervix, you'll pick up your radial margin. You'll pick up your vaginal/ectocervical margin very confidently if you have inked before opening. The second part of the question was she bivalves it instead of opening it along the lateral wall. And I did mention in my lecture that when you open it along the lateral walls, this gives you maximum exposure of the anterior and the posterior halves. You can identify your tumor extremely well. Earlier, we were also not doing this, but after the new protocols by the ISGIP project, I thought the lateral wall has greatly improved our way of measuring the tumor and our way of sectioning the tumor. And then it is very, very important that you section your uterus right away. When you open, you don't fix immediately. You first section and then you fix, because no amount, suppose you're doing some IHC post without sectioning, your MMR IHC will just not work. And the endometrium is notorious for getting autolyzed extremely quickly. So if you're not sectioning your endometrium at thin slices, parallelly from fundus to lower uterine segment immediately on opening, you're actually causing great harm to your endometrial tumor. You may not be able to grade it accurately later because there'll be autolytic changes. You may not be able to type it accurately also. You may not be able to interpret your ancillary tests also. For example, your MMR, your P53, etc. may not work if you have not done it on your prior biopsy and you're thinking of doing it in your resection specimen. So I think opening it laterally along the lateral walls will expose both the anterior and posterior halves very well. You can measure the size, and immediately sectioning and then placing it in a fixative will go a long way in producing an accurate histopathology report.
Yeah. Thank you. The next two questions are actually very practical. How is chemotherapy response assessed in ovarian tumor by only omental tissue?
So I was a part of this CRS scoring study, which was done by the great Dr. Naveena Singh, and I feel very fortunate that I was a part of this. So CRS basically scoring is done in the omentum, and from a practical point of view, you classify them into CRS1, CRS2, and CRS3. CRS1 means there is no response or minimum response, which means that there will be a lot of residual tumor. So for that, there is a rough cutoff which you can take. If you have more than 95% viable tumor and less than 5% fibroinflammatory response, then you are in the category of CRS1. CRS3 is the other extreme, where you have very good response, where you have less than 5% viable tumor or no tumor at all, no residual viable tumor, and more than 95% fibroinflammatory response with some of bodies or fibrous or inflammation, etc. Then you're in the category of CRS3. Now, in between this, that is between 5 and 95, when you see appreciable fibroinflammatory response, you are in the category of CRS2. Now, this CRS can only be assessed if you sample your post-NACT omental sections very well. Number one, you measure the omentum. Number two, you make very thin 5 millimeter slices in the omentum. Number three, you just don't take fat, you palpate it, because after chemotherapy, you may not get a solid gray white nodule sometimes. You palpate it for firm areas, for little different colors, like different from the yellow, maybe gray white or gray yellow areas. And then you take good sections of it. So the guidelines say, all guidelines actually unanimously agree on at least 4 to 6 sections. And then you do the CRS scoring on the one which is the worst. Take one section and then you do the CRS scoring on the worst possible section, which has got the worst grade. So if you're getting a CRS 1 in one particular section and 2 in one, then you choose that particular section which has CRS1 and report it. So that's how you do it.
The next question again is a practical question. It's regarding staging of tube ovarian tumors. So what is the purpose of finding the site of origin? What's the value?
Okay. So when it comes to morphologies like endometrioid or clear cell morphologies, tube versus ovary versus peritoneum, that doesn't come into question because they're mostly ovarian in origin unless they're arising from endometriosis. Now, for serous carcinomas, high-grade serous particularly, whether associated with germline BRCA or associated with somatic BRCA mutations, they are said to arise from the fimbrial end of the fallopian tube. Now, but in many cases of high-grade serous, we do not find with adequate CFIM technique also, performing the entire CFIM technique very diligently. People even say you do 1 to 2 millimeter. Then there's also 2 to 3 millimeters. So even if you go 1 to 2 millimeters sometimes and you do a CFIM, you may not get tumor, no stick or no mucosal abnormality or mucosal high-grade serous carcinoma in your tube. In that situation, you may call it ovary in that situation, and or very rarely peritoneum. But if you follow the CFIM technique, majority of the cases are going to be tubal. And that's what even we've seen, that if you do it diligently and in the right scenarios, the majority are going to be arising from the tube. And this is an important staging implication and a very important pathogenesis, pathogenetic association. So I think that's the importance of stage site for staging. Yeah.
So I think that's one of the question is regarding do you submit all cross sections of the tube as CFIM protocol or just representative sections of the tube are okay? So I think you just answered about that. Yeah.
Yeah, so I answered that also in my lecture. When do you stick to CFIM and when do you do a little modification from CFIM? So you must stick to CFIM when you have extrauterine high-grade serous, but with both tubes completely normal and both fimbria completely normal. In that case, you want to establish that yes, it is arising from the tube, and the best way to do it is you do the CFIM. You completely sample the fimbrial end, and then you completely sample the other ampullary portion completely in transverse sections. This will increase a 4-fold increase in you picking up stick or picking up mucosal high-grade serous. If you are dealing with a prophylactic salpingo-oophorectomy in case of a person who may be a BRCA1, BRCA2 mutation, in that case also, you want to find out if that person is harboring a stick or an early mucosal cancer, you should do a CFIM technique. Okay. If you're doing a BSO for, say, hormonal ablation in case of breast cancer. Now, breast cancer and ovarian cancer they are connected because of BRCA again. Same thing, do a CFIM for the fallopian tube. And even for Lynch syndrome, which is when you get prophylactic hysterectomies, you also get BSO, bilateral salpingo-oophorectomy with that. In that situation also, though the guidelines are not very, explicit, but even in that situation, you should submit the fallopian tube by the CFIM technique. Now, other morphologies of the ovary, like clear cell or endometrioid, you may do a little variation. You can submit the fimbria completely. First, make sure that the fimbria is seen or not, submit it completely, and take representative transverse sections of the fallopian tube. For benign, no problem, just take representative sections and submit the fimbria completely. So you have to know when to do a CFIM and when not to do a CFIM.
Okay. One question, interesting question is how to stage when there is high-grade serous carcinoma in bilateral tubes and ovaries, and what will be the tumor size?
So, how to stage?
How to stage if you have high-grade serous carcinoma in both tubes and ovaries And what will be the
So
tumor?
it will be a 1B provided your capsule is normal. There is no nick in the capsule. There is no tumor deposit in the capsule. There is no surgical spill, and your washings and your fluid submitted are negative. Bilateral will be 1B. And of course, your pelvic tissue should be fine, your extra pelvic tissue, your mentum should be fine. There should be no lymph nodes. If it's only that, it should be a 1B.
Can you comment on the tumor size here?
Tumor size. Tumor size has no, as I mentioned earlier, no bearing on staging, because a tumor size, but should be measured, is very important, because your tumor size will guide you to your sampling. So if your tumor is less than 10 centimeters, you will take 1 centimeter, 1 section per centimeter. If it is more than 10 centimeter, you will, take more. So for a mucinous tumor, you're going to take, if it's more than 10, you'll take 2 sections, because it's got a huge variety of appearances. So tumor size is not going to affect your stage, but it's important to document the tumor size. And if it's a tubo-ovarian mass, if your tube is entangled with your ovary, or it's a part of the ovary, your tumor site will become, for a high-grade serous carcinoma, the tumor site will become fallopian tube automatically.
Okay, I think I'll maybe take just 2 quick questions. I may not be able to go to everything. There's a very curious question. Do we have any AI help available to assess the tumor size?
I'm sorry, I rely on natural intelligence. I just take a ruler and measure it. Measure it in 3 dimensions.
Admittedly, no. So one more question is that I had a case where the tumor was squamous cell carcinoma, but ectocervix was completely normal, and the tumor was spreading to isthmus endometrium. So how to tell the origin of the tumor? Is it arising from the transition zone, or it's arising from the endometrium?
I had a similar case actually, where the tumor was in the lower uterine segment. It was squamous. It was spreading along the uterus, and also it went through the cornual, transcornual spread into the fallopian tube on one side. If I would look at it, number one, as I would do a P16 immunostain for sure. And I should make sure I'm not dealing with, was it involving the ovaries also, only the tubes? I'm sorry. Was it involving the ovaries also, Kedar sir? This tumor? Or just the tubes? Was it involving the tubes also? Or just the tubes or the ovaries? What was it? This particular
tumor was squamous cell carcinoma, but ectocervix was completely normal, and the tumor was spreading to isthmus and endometrium. I'm not sure actually from the question whether it is from the tubes involvement or no. Yeah.
So P16 would be a great marker, whether it's arising from below the lower uterine segment somewhere there, not visible grossly. I would look at that. I would make sure I'm not dealing with any serous carcinoma. I would look at that as well. I hope there is no teratoma in the ovary with squamous carcinoma arising from that. So I would look at that also.
Yeah. I think maybe I'll take just one more question. But there are 4 or 5 more questions, but I don't think we'll have time. So maybe this is the last question. If the omentum is free of tumor and the tumor deposits, but the primary tumor is still seen without any response in the ovary, how can we stage the response to chemotherapy in this case? What would be the CRS score?
Right. That's a very interesting question, and I usually have issues with that. So what I do is, when you're slicing the omentum and you are looking at the omentum, you should take, as I said, sections from not the pure fat, you know what pure fat looks like, but from the firm areas. Now, number one, before initiating chemotherapy, you will have access to the radiology findings. Was there omental disease to begin with? If the patient had omental disease to begin with, she should have some response. There should be some treatment. It's like a tumor bed in the breast, after chemotherapy. There should be a tumor response in the omentum. So you have to be very careful in grossing those particular areas. Any lumps, nodularity, you have to look at that and take those sections and establish that I have found treatment-related changes in the form of fibrosis, chronic inflammatory cells, sheets of macrophages. I do not see any definite foci of residual tumor. Therefore, this is a CRS3. no residual tumor.
Despite,
But if you,
despite having
yeah,
the tumor, which is quite well
yeah,
seen in the ovary.
yeah, it can happen. But if radiologically, before the initiation of chemotherapy, let's say the patient did not have Omental disease, it was and was then given NACT for, it can happen. The patient probably say had a positive pleural effusion. It can happen. You've had cases, but there is no Omental involvement. It has skipped the omentum and gone. It has happened. And in that case, you have to say prior to initiating chemotherapy, there was no omental disease. Now I have sectioned the omentum very diligently. Neither am I finding viable tumor, nor am finding chemotherapy related changes. CRS is not possible on the omentum in this particular case. So you have to discuss this in the NDT and put it as a comment in your reports. I would do that. And I've had such situations.
Okay. Divya, I think we are coming to the end of our time, and I really thank you for your time, your efforts.
Thank you so much.
I will apologize to our attendees that I'm not able to take some of the questions, but I'll need 1 minute to actually make some housekeeping arrangements. So after this, we have just for the information to all the attendees, the next webinar is going to be next Wednesday, 26th of February at 1:30 GMT or 13:30 GMT. I would ask all of you to check, depending on your time zone, what is the time which is suitable to you. It is usually arranged at 7 p.m. Indian Standard Time, but please do check your location and the time zone. And also to tell everybody that all the webinars in the series will be recorded and stored on our college website within the International Virtual Resources webpage. We aim to have the recordings uploaded to the website in about 2 weeks' time. Lastly, we also will mail everybody the feedback form. Please do take time to fill the feedback form. It takes less than 2 minutes, but it helps us a lot in actually getting how we are doing, and it also planning for any further webinars that we intend to make. So I think again, thanking everybody. Thank you, Giles Sandrati for his excellent and rock solid support, technical support. Divya, thanks a lot for your time.
Thank you.
From pathologist from this region, we thank all the attendees who have actually attended and posed us excellent practical questions. So I hope it is useful, and we'll meet again next Wednesday at 7 p.m. India time. So thank you so much. Thank you all.
Thank you, everyone. Thank you, Kedar. So thank you, Giles. Thank you so much.